for being in person. I know it's an effort. Only one away is not bad. And unfortunately, Alan Sager is not going to be able to be with us, but he has given, and Lauren was terrific. She reached out and said, is there anything you'd like to add given the richness of this conversation? And so we will have his input, even though he is not here in person, which was great. Thank you. Also, thank you for getting the minutes out so early. That was super. We've all had plenty of time to read them. So do I hear a motion?
So moved.
Thank you. Second? Second. Thank you. Any discussion about the minutes? Okay. None. I do have to have a roll call because I have somebody on Zoom. Okay. Brent.
Yes.
Adriana.
Yes.
Niels, you're on Zoom, but you can say something.
Yes.
Okay, thank you. Karen.
Yes.
Sandy.
Yes.
Jean.
Yes.
And that's it. David? No, we're good. Super. It is a really interesting agenda. Thank you for it. I'm expecting a terrific conversation, and I really appreciate the teeing up that you're doing for all of us. So I'm going to turn it right over to you.
Sure. And I'll actually have Andrew and Nick, you want to join?
I think, I'm not sure if every member has met Andrew, so that'd be great to introduce him.
Great. So for those that have not had the opportunity to meet Andrew and Nick, Andrew Jackma is our chief of staff and has actually been with the agency for like over 10 years, right?
12. Yeah.
12.
Who's counting?
Yeah. And Nick Dancer, who is our relatively newish CFO.
9 months, yes.
We're really excited to have and lucky to have joined the team. So the primary agenda today is to review our strategic plan, solicit feedback from all of you, and discuss areas and opportunities to update the plan, as we've always envisioned this strategic plan document to be a living document and serve as a guide to decision-making within the agency. But prior to digging into the strategic plan, in response to some of the council members' requests, and in order to really ground the strategic discussion, we wanted to do a readout from an exercise that we conducted that looked at our resource allocation, and specifically it was taken on to evaluate and quantify the amount of staff capacity and resources dedicated to statutorily required work versus work that we would otherwise sort of classify as more discretionary, yet reflective of policy priorities. So with that, I will turn it over to Nick, who will walk through the resource allocation segment, and then Andrew will lead us through the strategic planning discussion.
Thank you, Lauren. Nice to be with you this afternoon. So as Lauren mentioned, over the last quarter or so, we've worked with business leadership at CHIA to really understand how much of our work or staff capacity is dedicated towards statutorily required or otherwise policy, programmatic, or understood as discretionary initiatives. So just to kind of, over the last few months, we wanted to define the scope in a really standardized and objective way to understand this work. So we have some foundational definitions here. First, statutorily required, we understood to be mandated under MGL or general laws or other codifying regulatory provisions. Discretionary, so that's work pursued consistent with policy or programmatic priorities. Some examples would be for the statutorily required. You look at our annual report, mass health pricing work, discretionary, more recent health equity work, or workforce survey efforts. So also we look at analytic projects and analytic work streams. So these have finite starting and ending points. We have ongoing work. Oh, actually, thank you. And then we looked at FTEs versus headcount. So I'm sure everyone's familiar with the distinction here between FTEs and headcount. But really, we viewed FTEs as the best way to understand, really as kind of a proxy for capacity, as that's comparable across contexts, across various workloads. So that's kind of starting with our objective measurements and scope to understand, again, discretionary versus statutorily required. So second, we looked at all of our analytic projects and work streams, defining one period of time being FY24. So July of 2023 to June of 2024. And this is really just a condensed inventory and assessment of all of our analytic projects and work streams. Identified here, all of the ones that are not highlighted in blue, therefore, are tied to some MGL or statutorily required project. So, and as you'll see here too, it's important to note that 3 teams are identified across CHIA as really the foundation for all of our analytic projects and work streams. Notably, HIR, Health Informatics and Reporting, Strategy and Research, or SNR, and Provider Finance, PRO. Next slide, please. So this is another view of the same data, but really showing again that nearly 2/3 or 65% of our work is indeed statutorily required, 15 there given the time period of FY24. And this is also, again, looking way out. We looked at our analytic work. We wanted to have a grounding of our FTEs. So again, this is scoping way out across all FTEs for CHIA. Again, looking at the identified teams of Provider Finance, which is the light orange, SNR and HIR. So across those 3 teams, there are 45.6 total analytic, again, capacity that we've used FTEs as that proxy. I think it's interesting to note here too, so just looking at the impact and the footprint of our data operations and technology team, which really is so foundational and important to our collective work. And then there's a 31.8 FTEs, which is all of our supporting FTEs, which includes me, Andrew, HR, legal, finance, those teams that kind of support, again, those analytic teams, as well as the data operations and technology. So this is kind of the upshot here, is that then we took the 45.5 FTEs of those 3 identified teams and then crosswalked them to those statutorily required projects. And viewing here that 32 of those FTEs, over 32 or over 70% are indeed tied to a statutory mandate or requirement. So again, kind of, I think putting another way, the capacity of CHIA's analytic work is rather limited in a given year. That is all the slides that I have for this work. I'm happy to take any questions.
Perhaps you could give the council a little flavor for the 3 groupings that you put them in, provider, SNR, and how, what's the word I'm looking for? Transferable are they between projects?
Yeah, I think we viewed, there was kind of an inventory again of our analytic projects, but we did require that each of those teams led individually, that they only dedicated those FTEs for those inventory projects. So I think given the restrictions that we put on the scope of that inquiry, I think we did not account for the cross-pollination between those 2 teams.
Yeah, I think it would be helpful for the council as we get to the next topic is that if somebody's in the provider team, do they have the skill set if something was taken off that plate to go to another?
Yeah.
I would just add that the answer is probably yes, in that from a skill set, it's a lot of looking at numbers, a lot of like quantitative, qualitative evaluation and analytic work, but practically, the ability to sort of just take one and move to another team may be a little bit more challenging, but I do think that the skill set by and large is the same. I think the one exception that I would call out, which the Mass Health pricing team, which is a team within the Provider Finance, the PRO, the pricing work is probably our most like discrete most discrete work stream within our analytic teams. Because they're taking cost report data and sort of serving as back-end doing that back-end operations for Mass Health's, many Mass Health provider programs. So that's probably the one outlier of those three analytic teams. But just to the question of a flavor, HAR is the team, and this is certainly not to be an exhaustive list, but HAR is the team that takes the lead on the annual report, does all of the relative price, all of the TME, total medical expense, as part of the benchmark and PIP referral process. That all falls within the HIR team. The provider finance team, as I mentioned, one does the pricing work for Mass Health, but the other large sort of team within PRO does all of the hospital and health system financials. And then SNR probably has a most diverse in terms of their suite of projects and work streams, but include the Mass Health Insurance Survey, the Workforce Survey, health equity work, case mix, and the like. So certainly not an exhaustive list, but just some examples of the type of work that the teams do. Largely skill set transferable. Putting that into practice maybe could potentially be a little bit more challenging, but I think by and large transferable skill sets, with the exception of the pricing team.
I'm not sure, I might have missed the sort of the framing, and I can maybe infer that the reason for doing this sort of analysis of discretionary versus statutorily required is because there's not any wiggle room around statutory required stuff, right? In the sense that it has to be done. And so it's not discretionary. You don't have choices about how to necessarily how much to allocate for it. Is that sort of the main reason for doing that?
That's right. That's exactly right.
So the projects that are not required, how are decisions made in terms of which project to take on?
I think that's a great question. And this is in large part was the genesis and purpose for the creation of the advisory council was to provide direction and guidance. And so I think this is the goal and aim of the strategic plan, is to come up with sort of an alignment of what are the priority areas that we want to focus on, acknowledging that there are certain activities that have to be done because they're required by statute, but that there is a bench, albeit limited, of analytic capacity to take on those priority areas. But we want to make sure that we at CHIA are not doing that, creating those priorities in a vacuum. And so we very much want to use this opportunity, and part of the reason we sort of brought these two agenda items together as one, is to get the feedback from council about other areas that we should be taking on or doing more in, acknowledging that it may have necessarily mean that we have to take something else off, because we are sort of at a point of one in, one out, absent additional resources from the legislature.
Perfect segue to topic number 3. Other questions? This was helpful. Thank you.
Thank you.
So just very quickly before launching into the discussion of planning for phase 2 of strategic planning here at CHIA, we thought it would be helpful just to sort of very quickly take through some of how we got here and sort of do some context setting. So this slide provides a high-level overview of our strategic planning efforts to date. As one of Lauren's early priorities in the spring of 2023, CHIA leadership set out to develop a strategic plan to help guide the agency through calendar year 2024, with a commitment to routinely review and update the plan, working with the council. So the plan itself represents a strategic or more thematic framework, so not a tactical plan per se, as I think Faye has very helpfully sort of allowed us to distinguish.
Keep coming up.
And one that we would use to help guide decision making, again recognizing that we do have sort of limited capacity around discretionary work that we're able to take on. The plan itself articulates the agency's mission, core values, key priority areas, and it outlines 4 overarching goals for CHIA. Each of those goals has nested objectives that we have sort of, where we've defined additional detail on carrying those out. Once the plan was established, agency leadership sat down and developed a list of tactics that we've used to help implement the plan and monitor progress over time. And as a reminder, we last presented on progress to the council in January, at which time we promised to bring back the discussion as we started to look forward to phase 2. And this is part of our commitment to ongoing and robust feedback on the plan. When we were initially developing the plan, we worked with the council and key stakeholders and took that feedback, which helped us sort of, I think, materially improve the final product. And again, as we're planning for phase 2, we wanted to restart this feedback cycle and solicit the council's feedback.
So just so we can let the record show, welcome, Martha.
Sorry, I'm late.
Am I good to pronounce your last name correctly? Klasnick?
Klasnick. It's deceptively phonetic, as I usually describe.
Yeah, just obvious, huh? Klasnick, got it. And you are attending on behalf of Data, right?
Dana, yes, on behalf of the Secretary of Vermont. Yeah.
So this slide sort of just summarizes the core components of the strategic plan, the values, the priority areas, and the goals themselves. I'll call your attention to the middle column that in addition to our statutory prescribed work, the strategic plan outlines 5 priority or focus areas, health equity, workforce capacity, primary care and behavioral health reforms, access and affordability, and then supporting government agency emerging priorities. And informed by those priority areas, the strategic plan includes 4 goals. Here they are, as written in the strategic plan. The goals hinge around promoting and sustaining a model culture of diversity, equity, and inclusion, communicating data and analyses in a clear and actionable manner, expanding the usability and accessibility of our existing data sets, and developing and implementing a comprehensive data and analytics strategy. So this slide is just to give a flavor of some of the successes that we've had with implementation. I would specifically call out for the council that CHIA has worked with a consultant to conduct a SWOT analysis and host a number of feedback sessions with staff, which have resulted in a 5-year DEI plan related to the agency's hiring policies, recruitment, and retention practices. Near and dear to my heart, we have recently hired a director of communications and content strategy, and we currently have a communications plan that is under development. We have more recently developed a suite of data release reform proposals that would potentially streamline our data application process, reducing the turnaround time to get data in the hand of applicants, and potentially expand the users that we're able to provision data. And lastly, we have successfully collected relevant SOGI data from hospitals via their e-health records. So that's the sort of history of before we sort of pivot to forward looking. Are there any questions about the plan or our implementation to date?
And in addition, you were doing 1 million reports and sending out communications monthly, all the statutory requirements, et cetera. Implemented a lot.
Feels good. Thank you for noticing.
So with grounding.
Great. So these are just some considerations as we sort of started to think about approaching phase 2. And really, as we've sort of thought about it, I think we anticipate that many of the priorities and the themes articulated in phase one may sort of extend into phase two. And that's in part based on the fact that it's our understanding that the priority areas and the goals are still broadly relevant and actionable. And I think that's reflected in the fact that CHIA did not receive any new major directives from the legislature. And as Nick pointed out earlier in this discussion, CHIA has a limited bench of analytic FTEs and a smaller subset of those that are dedicated to our discretionary work. And that's just something that we've been sort of keeping in mind as we start to approach this next phase. And one thing that's maybe not obvious from the discussion so far, but I think it, they alluded to this in her comment, is that in addition to the goals embedded within our strategic plan are other concepts that place additional constraints on our staff, things like asking them to work on AI and the PCD project. So all of that sort of just informs our thinking and our sort of conclusion that we're likely at a place where we are talking about this sort of one in, one out for new major initiatives in phase two. All that said, we have identified some potential discussion prompts that we think would be useful to hear from the council, but I think if anyone wants to jump in sort of at any place, we would welcome thoughts or feedback.
This is an answer somewhat to Jean's question. This is the time to weigh in. I do start with a question though. We have a list of, I think there were 8 discretionary this year.
Correct.
Do they continue in any way or are they off the table now? So we can fill it in. Okay, but
I will toggle back to that. But
it was the one with the blues. In other words, are they complete?
No, the answer is no. Sorry, I wasn't sure who was taking that. Yes, these are all ongoing items, so we don't expect any one of them to. I mean, for workforce survey, for example, we have plans to redeploy that survey in 2025, and I think absent feedback to the contrary, for example, from the council, our plan is to deploy that and field that survey on an every other year basis so that we can trend the data and look at it, help us evaluate, help policymakers, the administration, the legislature evaluate whether certain investments or policies are helping the healthcare workforce or moving the needle in any way. So the thinking has been to continue on with that. But again, this is the opportunity to really pressure test and hear from the council as to whether these are the right sort of discretionary activities. And if there are others that we want to put on the list or consider in the future, what things would we have to potentially hit pause on or defer, put on a slower track, for example.
So for the sake of discussion, I think it'd be great to start with the things people would like to add before we try to figure out what would go if they were added.
I'm interested in I really like the data usability sort of goal and backing that with the data analytics strategy. And I know that in terms of I think it's great to have the automated framework for data quality, because, if it's not very usable, if it's not, good quality and that type of thing. Have you thought about sort of particular metrics, or how are you sort of gauging success in terms of data usability, that type of thing?
well, I think that's an area where as we think about the goals in the plan, they are sort of not entirely symmetrical, and so I think some of these are bigger sort of concepts than others that are captured there, and I think that our data usability is one that is sort of one of the sort of larger pieces of the pie, and that's an area where I think there's still room for sort of defining what those metrics are. I think we've made some headway, but it's still probably not as far along as some of the other areas.
Yeah, I mean, I think certain metrics that are kind of on our radar are time to turn around. If some of our data requesters, if they feel real or perceived that the time that it takes for them to apply and actually get the data is too long, it doesn't meet their use case, that's a challenge. And I think that's just one example of a metric that we're trying to improve upon. I think with respect to our EAPCD, the whole genesis of the project was we needed to have be a very sophisticated data user, be sort of a master on SQL, to be able to sort of get in and play around with the APCD. And so that was the whole genesis of creating the EAPCD or the enhanced APCD, was to allow sort of your entry-level analyst to get in and query the system without having to have a PhD in computer science and data.
Yeah, that makes sense.
So I don't think that we have like a one size fits all metric to evaluate and measure data usability. If you have thoughts, we would welcome, but because as Andrew said, it is a fairly expansive goal with a number of different dimensions to it, we are sort of putting in place a metric for each dimension.
Yeah. One of the things that all makes total sense. One of the things I think we talked about before, and that I think there have been aspects in some of the work that's been done, is this idea of when people come to you with requests for data, like how do we do that in such a way? It's kind of tied to what you're saying about time to sort of produce, but it's more about like, is there a way that we could do this so next time it's not like an ad hoc request, it's more of a self-service type of request, and of just sort of like it's about organizing things and making them so that they're in the form that people can easily get at the data. You know?
Yes, and that is sort of one of our primary agenda items or plans for this coming year as part of what we're calling data release reform, is to come up with, based on historical requested data. We know that the requests typically follow a certain pattern. And so coming up with off-the-shelf, what we're calling off-the-shelf products that are de-identified and that would be ready to go, with a 1 week turnaround at most. So those off-the-shelf products are something that we are currently doing a lot of thinking about, going through the inventory of historical data requests, making sure everything's de-identified, but would still be fit for the purpose that we anticipate and have seen requesters come in looking for the data for.
Yeah, that's great. And one of the things about that sort of process is that it can be sort of a virtuous cycle in the sense that when you are able to sort of turn things that were a lot of work to sort of gather or put out and make that so that it's sort of easier, that gives more time to do other discretionary things or to work on others.
Yeah.
Other thoughts from the council? I am going to ask you to talk a little bit about communications, since you seem so excited that you're going to have somebody.
Great.
What can we look forward to? It's one of the things we've talked about for the last year or so.
Yeah. Is there
Yeah.
a
What do you-
specific area that you want to sort of delve into, or?
I think a little bit of it follows on Brent's point of making it, first, people aware, being the source. We want people to know, therefore we exist, and you want it to be incredibly easy to access us.
Yeah, and I think those are all sort of principles that I can sort of do a sort of break down the board. Well, Lonnie is our sort of director of communications now, and sort of these are the type of things that we are sort of constantly meeting with on a weekly basis.
That's why she's nodding.
And talking about, and I think that is really the opportunity. And then sort of in addition to that, it's, how do we create a process whereby we are sort of like getting some feedback right now, because I think that is a sort of a part of the process that is not, there's an opportunity there to sort of like expand upon that. And I think that's a really important sort of thing for us to know is sort of we put these things out there, how are they perceived? How could they be improved upon? How could we make them more actionable for our intended audiences? So these are all things that we're trying to memorialize in a communications plan that we will sort of spend the next year carrying out.
And then following Brent's thought also, how do you know you've succeeded? What are the metrics?
Yeah, these are all things that I think working with Lauren and the rest of the leadership team, we want to sort of agree upon what are the most important metrics. But we know that there's there's some of them I think are sort of obvious around engagement and sort of trending that over time. And as you're well aware, I think our appeal is not to the whole universe, but it's to sort of a subset of people who are really sort of dialed into healthcare data, but making sure that among those intended audiences that we are sort of getting to them, that they're sort of staying constantly engaged, that they find that our reports and publications and data products are in fact helping them answer the questions that they're wrestling with. I think those are some of the things that we're trying to find ways to quantify.
So recognizing that CHIA as an agency has limited capacity and also that you're trying to sort of democratize and liberate this data a bit more, does the agency do anything to sort of collate the research products that get generated using CHIA data but not conducted internally? Is there a way to sort of create a library?
We actually, so buried on our website is a page that does just that. And so again, I think this is really useful for us to hear that like this is something that has been out there for a number of years where we sort of as a condition of handing out the data, we ask people, let us know when the project is done. We then sort of, look at that and post that on our website. We sort of share those things out via our newsletters. Again, just to help generate ideas about the possibility of what can be done with CHIA data. But the fact that one of our council members is not aware of that, I think speaks to the opportunity to.
You're not alone, I'm sure.
So.
But maybe to sort of answer a question with a question back to the council members that I'd be really interested to hear your thoughts on is there a way to, do you all have ideas for either creating sort of feedback loops so that we can understand when we put out a publication that is say 100 pages long and you all look at it and say, this data would have been much better, much more usable, more accessible as a 5-page or a much shorter chart pack, for example. Do you have ideas for creating a feedback loop so that not only council members, but folks from the industry, the legislature could provide us feedback based on various publications? And or do you have ideas around metrics for measuring the success of sort of revised, reconfigured, reformatted different publications and information?
I think what you said about sort of keeping track of requests and then keeping track of the results, like you said, and keeping them around. It's hard to measure sort of the impact that the uses of the data have. But I think in terms of just, I think just having metrics around things like the sort of number of requests and I don't know, maybe like what areas, like is it coming from the which sort of set of data are the requests coming around and just sort of like, I think would be an interesting sort of thing, just to see like what are the products that everybody's sort of most, or the big hitter sort of things versus things that we keep, but doesn't seem people are paying much attention to.
Yeah, yeah. And I think I see sort of two buckets. One is there's the data requesters, but then we also have, which I think is probably a larger share, is the individuals that come to our website looking for data. And it's not they're not requesting the big massive data extracts, but it's the published data. And so I think one of the challenges, one of the metrics that we're using now is hits on the website.
Downloads.
But that is not a great proxy for usability, because the amount of times I've gotten a call, someone that has people that would have in their careers access the CHIA website. Many times they call and say, I have nowhere, I'm searching around on your website, I can't find this, I can't find that. And so I don't think that pure traffic is a great way to measure, but how can we measure sort of usability if we're making improvements on our website, which we do have sort of in the plans? How can we measure the effectiveness and accessibility of it?
Lauren, I know bandwidth, will be something that's overarching that, kind of executive staff leadership will have to juggle, but it seems just from this conversation that CHIA has, CHIA staff has a reasonable sense of kind of ecosystems of users. So, I think we all have had experience where, having kind of a standing group, of 3 or 4 or 5, you do have to check in with them, kind of before and after, or, more than once over a period of kind of like, 9 to 18 months. Strategically selected based on when something gets released or when, there's a before and after something changes. You can imagine more, sort of for research purposes or, CHIA data being ingested into work that's, more national in scope, compared to government colleague users, compared to, you've mentioned private, kind of different ecosystems of users. When you mention, how useful people are finding things, I don't know if the new director, there's a lot of kind of pretty kind of low intensive, kind of automated ways to get some information back. Like you all have distribution lists, and there are automated ways to track how many people are clicking and how quickly they're clicking upon receipt of that email. I wanted to make a plug, sitting from a government perspective, and there's a whole ecosystem, on this slide of, standard recurring reporting that Massachusetts has become incredibly dependent on, I think, in a positive way, where there are structures that are built around anticipated quarterly and annual reports that allow us a level of insight, having practiced in different states, that is really remarkable. And so sometimes when the train's running well, and on time, there isn't always that, real-time positive feedback. And I want to express that very, very, very strongly, from workforce to the new behavioral health and primary care work, to the, steady state reporting on costs and expenditures, price, all part of the annual hearing process, as well as really information that's unparalleled in its nuance around the remaining uninsured in Massachusetts through the Massachusetts Health Insurance Survey, the employer survey, and so on. That we got a group of stakeholders from around government to chime in on the health insurance survey recently. And again, there's not kind of a week that goes by where I don't see a report from another agency that depends on, something that CHIA produced to be able to do their work.
I appreciate that. And I think maybe it's just worth sort of calling out, because we certainly didn't intend to throw cold water on the discussion by starting just with, this is our limited analytic bench, and it has to be a one in, one out, because I think while we are sort of at capacity, from kind of new, like, discrete projects and work streams, and it probably would have to be a one in, one out, as we've been using. I think it very much depends on the nature of what it is. Because if it's standing up a whole new data stream, or we're standing up infrastructure to collect data, wholly new data, and running the analysis on that, yes, that's going to be a large lift, and would likely come at the expense of another project or work stream. If it is a new analysis that relies upon data that we already have in-house, that is something that, you know, we may be able to take on without having to sort of put something else fully on pause or on hold. So perhaps if we just can hear some of the topic areas or themes that folks would be interested in us exploring, we could then assess, like, is this something that would require a whole new data stream, or is this something that we could do with existing bandwidth?
I appreciate giving a sense of resource constraint for a group before you really open up the question, but I think it's time to open it up a little bit in that direction, because we exist to provide unbiased data to answer questions. So what are the questions that you would like to see? And I think this is your question, Jean, also, is how do we get new questions on the table, if there are any from this group?
So one topic that came to mind for me, in part because of our agenda item after this, is sort of the demographic shift and the long-term care needs we're going to have as baby boomers, you know, age into long-term care, and what sort of planning does the state need to engage in, given that a lot of that is going to be footed by Medicaid and not at the 90-10 rate? That's something that I think is very cross-cutting. There are health equity implications there. There are coverage and access implications there. I don't think that requires a new data stream, but it is maybe a topic area that is not currently a focus and doesn't need to be a focus this year or next. But I think Massachusetts has an opportunity to be a leader in sort of how can states be proactive about planning for that increased demand for nursing home and long-term care.
I think that's great. Yeah, so I think I want to just make sure I paraphrase. That you're interested in the impact of our aging population on the healthcare system.
Yes.
Broadly,
and it has state budget implications, like really important state budget implications.
so many implications for some.
I think I would just pile on that, because this is such an important point, maybe slightly broader than just the aging population, but overall capacity of the system, you know, is irrational. Because in theory, if we have perfect markets, then capacity will take care of itself, but it's not a perfect market. And then there's a lot of government controlled space, and there's a very complicated system. Consumers are not always informed. So you end up having system capacity not being in a very rational state, and some places are very, very tight, but we don't necessarily know it until something bad happens, right? So ideally, we have a rational way of looking at, if you look at the whole system from acute to long-term, think about the whole population shifts, is capacity moving in the right direction? Otherwise, I'm just sort of pausing, because this list actually aligns very, very well with the priorities. So I would, just say kudos to CHIA coming up with this list of projects. I'm assuming most of them are going to be recurring. So maybe every year we talk about one or two new ideas, and then do some thinking around who are, to Karen's point, the 3 or 4 cohorts of natural users that we, in a target way, sort of collect some very, very purposeful answers to those questions.
Others? Did you want to say something?
I was just sort of aware that some of the themes that Jean had identified sort of lined up with some of the feedback that we received from Alan Sager and Lauren. I know you wanted, before we sort of ended this, wanted to touch on that. I don't know.
Yep, yeah, perfect segue.
Yeah, if there's no other thoughts.
And we can circle back, so keep thinking.
Yes, and yeah, this, and perhaps this list may spur some additional thinking. So as Faye and Andrew mentioned, we had an opportunity to connect with Alan ahead of this to get his feedback, and had sort of committed to relay and make sure that it was on the record as part of our strategic planning conversation. So he gave us a list of 7 that I hope that I can do justice on, but feel free to jump in if I got any of this wrong. So first item was analysis of urgent care centers and ambulatory surgery centers, including how many, geographic distribution, how they're staffed, et cetera. The 2, quantification of the primary care shortage, understanding what is causing the shortage, steps to remedy the shortage. Along the same lines, a supply side survey of physicians, specifically primary care physicians. For a further analysis and understanding of the differences between our state healthcare spending figures. So our annual, what we report out as THCE in the past, it's hovered around 70 billion, and CMS's sort of mass specific spending figures, which have typically been closer to the order of 125 billion. So understanding the differences in how we calculate in the methodology. 5 is along the lines of, Jean, what you were mentioning, is sort of health planning to get ahead of the next emergency or contingency. 6, an analysis of the impacts of underinsurance in the broadest sense of the term, so including both underinsurance from a financial affordability standpoint, as well as underinsurance from an administrative sense, so plan designs, coverage limitations, and then finally, better quantifying waste in the system and the sources of such waste. So again, these were just suggestions offered by Alan, with the acknowledgement that some of this work has either already been done by CHIA or other agencies, and or maybe better suited for another agency to take on. But that was his wish list, but would open it up for any thoughts or if that spurred any additional ideas or thinking.
There's a little bit of overlap with the capacity question on a couple of them. If I look at, you were saying the overall capacity, and he was adding, make sure don't, I think saying, don't forget urgent centers, all those others.
Yeah, right.
And
You
then
know,
primary care.
There's always, again, we can look at surveys, but wait times, right?
Mhm.
So we can potentially systematically collect data to look at the system, identify the major fragments, saying, is there, if our hospital beds are 95% full at all times, that means we have capacity. We should probably create some room. If primary care appointments always have lots of wait time, then we have a problem. So is there a way for us to kind of think about the whole value chain of system? Because what happens is when you have a bottleneck, everything else is messed up, right? So what you want to do is ideally rationalize your capacity along the chain. As if if people getting stuck, then it's not very efficient. So that creates waste as well, right? Because they're not getting the right care in the right place. So you're misusing available resource. So therefore, you cannot just solve one problem. You really have to think about the whole system. And I actually think this is very aligned with the CHIA spirit. Most of your work that you have done, whether it's affordability or trend or enrollment, it's all across the system. You don't just look at one fragment of the market. Can we think about capacity this way as well?
Yeah. No, I think that that makes a lot of sense and is consistent with, and this is where it's been a little bit challenging over the last year because we've been in a wait and see sort of state of being with the pending legislation that didn't quite make it out of conference committee, but that established the Health Planning Council within, actually moved it from AHS to HPC and had sort of a directive to CHIA to essentially supply the data and analytic resources to support that council. So I think that we were knowing that that was coming down the line, tentatively. We had, I think it's, I'm happy to connect with David after just to make sure that, he's up to speed on there's feedback and considerations from this meeting. But it is something that has been a somewhat dynamic and that we haven't, I don't think either agency has wanted to sort of take it on or start it without knowing where the legislation is going to land.
Yeah, this
And I
is a
think we're
huge
still
topic,
waiting. Yeah,
of course.
yeah,
So,
yeah. And so maybe one, in the interim, as we're still sort of waiting to see where the legislation lands, thinking about are there incremental,
like Alan's
and that-
list,
yeah.
maybe we can try out some pieces.
very incremental. But I think there are certain things that she is already working on, for example, the primary care, where if there use that as a building block to say, what additional questions do we have about capacity and what planning efforts can we take on in the immediate term related to primary care, because we do have a solid set of data in that domain right now. Instead of, until we sort of know where that broader language is going to land.
If I can pivot from the workforce and capacity stuff, another thing that I'm sure is already top of mind, but I think is worth touching on is the GLP-1 semaglutide drugs and what that means for spending. And I think that, it reminds me when the Hep C drugs came on the market. This is a thing that happens periodically. And I think not only evaluating the current, drug spending issue, which I know the connector just said that their rate hikes for 2025 are largely related to these drugs. I think having a sort of framework for quickly doing analysis for things like this that are very top of mind for folks, very much of interest, could be helpful. So I think had there been something that you could sort of, that was plug and play for Sovaldi, and you could plug and play with the GLP-1 drugs, you could be ready for whatever the next thing is. I have no idea what the next thing is, but there's always a next thing. And given that it's affecting, I assume it's also affecting employer premiums in the state, but I don't know about that because I don't have that data. You guys do.
Yeah, and so HPC did an analysis on this based on APCD data.
Got it, okay.
But would be curious and happy to sort of circulate that, because I would be interested in your feedback as to are there additional questions that weren't addressed, say, in that analysis. And I think I like your idea. My team knows that I love a good framework, but I like this concept of taking a framework that could be more plug and play, so that for the next thing, it's CHIA and the HPC can truly sort of plug in with our data that we have, and if it's appropriate for HPC to run more of the analytic piece of it, then so be it. But I think it makes a lot of sense. It's something that I could talk to David.
I like the idea also of comparing it to the other situations like the Hep C drug. I mean, each time it's like a new thing.
Right,
And it's not. So comparing would be really interesting.
Can I just ask, what information would you need that you don't have already in order to anticipate the next Sovaldi, the next GLP-1 drug? I know in the past there's been ideas kicked around the legislature around, giving advanced lists or some kind of pharma heads up, right, on things. I'm just curious as to what information do you have enough information, maybe starting there, in order to anticipate these next drugs, to kind of start tracking them early enough to start seeing the uptake. Because I imagine that's part of it, right? Where it's, if we started tracking Ozempic right now, it would be a much different story versus, when it first came onto the market, and even just seeing that initial uptake. But you have to be able to know to look for it.
Right.
And I don't know the APCD well enough to know what you
Yeah.
would have already and what you would need.
Well, I think it would be interested in others' thoughts, but it sort of depends on what the root of the problem is. So if it's with the GLP-1s, it was the utilization.
Yeah.
It wasn't necessarily the list price. And so the utilization would be hard. It's hard to project or forecast, although I think everybody was right on and saying like, yes, this is going to be an explosion of utilization. I think the obvious answer there is we don't have self-insured, so we don't have the over half of the commercial market in our APCD, but we can extrapolate, which is I think how HBC did their analysis. Like to your other question though about really high cost drugs like the Hep C drugs, when those came to market at exorbitant rates, that's where having that advanced notification legislated so that the manufacturers are required to provide advance notice, that would enable us to do that analysis to say, okay, here's the only Hep C drug on the market right now that's been approved, and it's coming in at $500,000 a year, for just, I'm making these numbers up, but that would be helpful, but would be interested in others' thoughts.
You can imagine having, if you, I mean, it sounds like there's different things, but it sounds like overall impact on sort of insurance and on the healthcare. You can imagine if you had sort of different things that were like high cost and or utilization that's just being used a lot more, you can imagine just sort of having things in place that say this is going up very quickly, just having some sort of that goes across all the different medications that are being, trying to, but it sounds like there are enough sort of different ways that it can happen, but you can imagine building a model, I guess, just to sort of measure some of those types of things that could be impact on the system.
But obviously, it's not a data-focused question, but I'm just thinking, given how important something like GLP-1 is in terms of changing the pattern of healthcare spending, should CHIA or policymakers in general expand the sources of information? For example, GLP-1's impact. The pharmaceutical biotech industry knew 3 years ago, way before, things started to show in the data. Biotech industry, I have some friends, they 3 years ago, they said the pharmaceutical companies, which typically, buy small companies as pipeline, they close up because all of their attention is directed to GLP-1 because they knew how important it was. So this kind of information is present in the industry well before data becomes available. So one thing I actually like, sorry, who said, is it Lauren or was it Brent, just saying, is there a dialogue, a structured forum with industry representatives from the pharmaceutical? We have a roundtable. What's happening? What are the things that we don't see in the data, but you already know because you see the research, you have dialogue, so that we can have a little bit more insights on what to look for. So that way, I think we can. But anyway, just a thought. I'm just thinking data may not be the only source for very important information.
Yeah, it's a really interesting question because our mission, our charter is to look at the data.
That's right. Yeah. So
But one can consider this, anecdotal data.
But to Martha's point, like what should we try to wrap our heads around before data becomes so prominently available?
So to think on.
And I think that just to add to the table of things on this topic about drug prices and the impact, one of the areas that the pharma industry has annually requested of CHIA, and I think is a fair request, and I think is extremely relevant when talking about GLP-1s. Right now, the focus is how much we're all spending, how much the system is spending on GLP-1s today. But there has not been, at least I have not seen sort of some solid analysis of what is the long-term impact of spending on GLP-1? Is this the right, are we spending, is our money today being well spent to offset and defer sort of, or not even defer, but mitigate or reduce long-term costs, and who are those cost savings accruing to? Because I think that type of information would be helpful to employers as they're wrestling with, do we cover this or not? So I think it's just another flavor of the type of analysis that we could do, and it's certainly something that the pharma industry has more broadly been looking for us to do, is that what is the offsetting, any savings of certain drug offsetting costs on the utilization end of the delivery system.
Yeah,
but
really interesting question.
it's interesting.
Yeah, very much so. Other thoughts? Otherwise, I'm going to summarize what I've heard so far. This is a summary, so don't worry, there's more detail. Data visibility, we spent some time talking about that, and communications. We talked about capacity, and that I broadened with David's point, so it's capacity of system, make sure you don't forget about urgent care, ERs, primary care shortage, et cetera. We had a great conversation about drugs, and the next, and first of all, analyzing what it is now and looking back, and then thinking about the future. Can we then broaden it to insights and sort of the canaries in the coal mine that we can pay attention to, because we're going to have to start collecting data as soon as possible. One of his points, I think, is one that if you could just give us, I don't think it's a big project, and that's why are our figures different than the feds? I mean, it should be, it should be at least close. And maybe just somebody sitting there figuring that one out. Would be great. And the two that we really didn't talk as much about was the impact of under and insurance, financial, administrative. Now you're doing another one of the surveys soon, right?
Yeah, so our mass health insurance survey will be fielding in 2025. So that's an every other year. And that will look at some of the access barriers, coverage barriers, knowing that we have one of the highest, I think the highest coverage rate in the country, really digging into the population that may have coverage but may not be able to access services even with that coverage, and what are the reasons why. So we're sort of in survey development right now for that, and planning to field that in early 2025.
Yeah, I think there's a financial, and I think there's, and I don't know whether the survey gets at this, the understanding the education, how do I deal with it? Maybe I actually have coverage and I don't use it, because I think I mean, one could go down a rat hole here and put a lot in, but I think raising a good question for the next survey next year. And waste in the system has something we've been talking about for a long time all over the place, so it's a toughie. So just how we think about it, is there anything we can add to that conversation? It's been, I've been in healthcare a long time. People have been talking about waste in the system for a very long time. So I don't think we have an answer to that, but at least a play. Did I miss anybody's thoughts?
Very good sign.
Terrific, great. Okay, next topic.
Now we'll move into our key priority area and updates, but first is a follow-up from our last council meeting on the nursing facility transparency work. Please.
Alrighty, so this is a follow-up from the conversation we had the last meeting, where we really sort of put forth the proposal we have for the Nursing Facility Transparency Initiative. So just to give kind of a quick brief overview, the intention of this is to increase the transparency of the nursing facility, both financial, quality, sort of characteristics of their data, but using our existing data sources. So either the cost reports that we're already collecting or publicly available data sources that we could leverage for this use. And the intention is to essentially, what we're putting in quotes as profiles for the nursing facilities, which is something we do on the hospital side, but it would be within an interactive dashboard. stars. So that is sort of our initial proposal to get this out there. And then similarly, to really just centralize, improve accessibility, all the things that you all were talking about, to let these cost reports that already exist, but are only currently available via public records requests, to be available and more accessible on the website. So that's sort of, it fits in with a lot of the themes, I think. So just a quick update on the timeline for that is that we have started our initial analysis of the nursing facility data, including 2021, 2022, 2023. Our intention is to send out a preview of this data to the facilities themselves. They will have the opportunity to correct their data. And then we will be sort of moving forth with the creation of the dashboard, with expecting to still publish by the end of this calendar year. So that's our goal. And then leading into next year, what I keep calling version 2.0, we'll start to bring in some of their sort of related parties, things like their management companies, their realty companies. So that's sort of the overall brief overview of what we talked about on the last time. But during the last meeting, there were specific questions, especially about the quality data that was available. So we wanted to dig into that a little bit deeper today, rather than all the exciting financial data I usually bring everyone. So we really looked into three main sources of data, which would be the CMS 5-star rating, the DPH nursing home survey tool that's available, and then something which is called hours per patient day, which is really a staffing ratio. And so these are sort of the three main sources that we have. This just gives kind of a quick high level comparison. There's plenty more, but one of the things to keep in mind is that a lot of these do overlap in some regard. So the CMS 5-star rating does include the DPH survey data. It also includes the payroll-based journal data that is used to create the hours per patient day. So there is a lot of overlap in this data, but there are different ways of sort of presenting the data that we could use. And so just one thing I would say of note is when we did sort of start to speak with other stakeholders and people, interested parties, the few that we had sort of been told would be, I think, especially helpful is the CMS 5-star rating. They are sort of very easily understandable. It is on a scale of 1 to 5 stars, and it includes all of these, it includes the DPH survey within that. And then also the hours per patient day, which is a staffing specific score, which I know is something I believe was mentioned during the last meeting as well. So as part of this, we really just wanted to bring these options to you all, see if you had thoughts on what would be the best. Is this something maybe we should include all of them within this new transparency initiative? Are there some we should focus on? Is there any other that maybe we aren't thinking of at this time? So we wanted to sort of bring that back to you all for discussion.
Can I start with a really stupid question? When you say nursing home, is that skilled nursing? Is that long-term nursing? Is that what my grandmother called a rest home? Is that, you know?
These are the skilled nursing facilities.
Okay, thank you.
Yes.
So not restaurants.
Took me a while to do this as well. I was living in a hospital world for a long time, so they're not interchangeable is what I had to learn.
Exactly.
Yes,
And
these
if
are
you're
the
gonna
skilled
deal with
nursing
all of them. I was gonna say, okay.
This might not take till the end of the calendar year for that.
So Liz, it looks like the data is almost done, right? September 2024, you're concluding the analysis.
Of the data that exists as of today. So we are giving the facilities the opportunity to look at this data, in particular, in some cases, because especially on the financial side, we haven't calculated the metrics for them in the past. So for many cases, they are seeing the way we calculate those for the first time.
I see.
But the data itself was collected
Okay.
either years prior or earlier this year. So it is already available data.
But it just, if we were to look at the metrics and say, hey, maybe this and maybe that, is just sort of, is that for the future, or you're still finalizing the metrics?
Finalizing for the quality, certainly. And especially if there are other financial metrics we're not considering. I know there was a large list that we can share of sort of everything we're considering, but the quality was one that we'd actually just put on as quality, essentially.
Right.
And it was that we wanted to have a quality score of sorts, but we hadn't gotten into the detail of what would be the appropriate choice.
Right, so the quality scores exist, I think at varying cadences, like the CMS star is I think on a longer cycle. The DPH scores can change sort of after
when the
one
survey occurs.
And the
And
HPPD, I think,
Is quarterly data, yes. So there's varying cycles, but all the data is out there as of a certain date. Our expectation is we're gonna sort of pick a cutoff date of whatever it is that we're using to publish.
Is there any difference between the different types of things in terms of the quality of the data itself or the consistency, or are there things that we're worried about in terms of it not being representative or things like that? Or is it all, I think, valuable for people to see?
It's all valuable. It's a lot of overlap, truthfully, at the end of the day. And that's one of the things is sometimes is it sort of information overkill or is it worth it to have it all available? I think some of the other things we've considered is also, these are publicly available data sources. They're not CHIA data sources. So we can also link out as an option, things like that, to make those that are interested available in other sources. We were focused on what would we put into a dashboard form so that someone could see if they click a specific, I can't even name them unfortunately off the top of my head today. If they clicked one facility and they would see sort of a score related to that. But it is possible to put all options there.
So somebody's looking, they click on XYZ facility and they would see a financial report and a quality score. And
The aim would be to see a whole bunch of characteristic information that you could learn about that facility in one place.
I would say to your question though about inconsistencies, there could be a scenario where a facility has, let's say, a 4 or 5 star CMS rating and a low DPH score rating, because the DPH scores are more dynamic and fluid based on a given survey. So if they have one bad survey, that could ding them sort of in real time on their DPH score, where the CMS scores are there's sort of a fixed star rating distribution and they only get updated. I forget what it is. It's like every year.
It's a very odd schedule.
So I think that's why it's important to say, what is the purpose of putting this data out there? Who's the audience? Is this for someone to come and look to see where am I going to send my grandmother, which could be a potential use case. I think that we were envisioning this more for policymaking, but I think that's a decision for the Oversight Council. And based on the purpose of this dashboard, putting this information out there, I think that should inform which of these metrics we use, because I think it would be confusing for someone to come on the website and say, how do I interpret really high CMS star rating, but a really low DPH survey tool, I don't even know what that is, rating. It's one consideration is, given the CMS star rating includes sort of accounts for the DPH score, does it make more sense from a usability and understanding to just include the CMS star rating and the H hours per patient day? Because those are two metrics that I think are understandable. When you start putting multiple CMS, a DPH score that may be conflicting, that could become a little bit more confusing from an interpretability standpoint.
To the point of who's it, there's one thing that's who's it targeted at, but I think it's going to be on the public website. And so I think people are going to use it, the consumers are going to use it, even if it's not targeted at them.
Yeah.
And so I think it would be good to have it to be as explainable as possible. I mean, I trust you to make sort of the right decisions around that, but I think it would be, personally as a consumer, I would sort of kind of like to see more data. Even if it was conflicting, it would give me some information. But again, if we think that the DPH sort of getting dinged for we don't want to put our fingers on the scale, but if that's just an indication of a short-term thing and not a long-term something, and but overall as a consumer, I would probably like to see both.
So I feel like if I'm reading through this, I think the CMS 5-star rating is probably the most digestible thing by far. But if I'm thinking about this for a relative, I'm really interested in the complaints and the enforcement actions, especially if those are a census and not just if it's over the past year, we know that there have been this many enforcement actions, and how does that compare to the state average? That's something I'm concerned about. I also think that making sure that the staffing levels are put in a format that is interpretable to a layperson is really important. So, one nurse assistant for every 4 patients, like, means nothing to somebody who doesn't know this, but how does that relate? Is it above or below CMS's like expectation? I think that the payroll-based journal can be used to make those assessments. And so I think that that's important. And to the extent that I think the payroll-based journal also has staffing information for different levels of practitioner. I think like maybe there's an aggregate measure, but I actually think it's important to have the disaggregated measures too if nursing homes may be performing well with one type of provider, but not so well with the other 2 types or whatever.
Does that make sense? And I believe there is, I think a federal, but there's also a mass specific sort of hours per patient day statistic that I think we were hopeful to use as sort of a benchmark to exist with this. And I think that would be the goal, certainly, which makes sense.
So do I take it from the council that you're giving feedback that this is used not just for policymakers?
I think it will be, right? It'll be publicly available.
Yeah.
But I mean, I know that there's research using the payroll-based journal. I know that folks who study nursing homes use this as a quality measure. So I think it's important to include.
I'm hearing more is better than.
And I think certainly from our standpoint of like building it, so to speak, I think we can now try it that way, hearing everyone's feedback, and you'd actually get to see in real time maybe what this looks like, which might be better to react to than us just sharing, a table of 3 to actually react to what it looks like for a real facilities data, which I think
It
certainly.
was interesting that many of us immediately leapt into, can I use this for my relative? But we haven't done that in every report.
Can I just ask one question though on, the one thing that makes me curious, or one thing that gives me a little pause about the more quality information that is provided on there is, does that then present a presumption that CHIA can then explain to the person all of the granular differences between those quality spaces?
Some of the model is.
Yeah.
Well, I generally
I-
am curious from like a sense of like, if I am looking it up for my grandmother and I see that this is on the CHIA website, do I then call the CHIA line and say, hi, I'm trying to figure out why, St. Awesome's, SNF can't have the same ranking between the 2. I don't really know what this means. Can you help walk me through this? Are we setting up an assumption that she is able to do that sort of work? I just, at minimum, I wonder if there's like some sort of disclaimer or something that you want to put on there to put that out there, but because I'm not against people sharing more information than less, but I also worry about the expectation that you present by the sort of data and the stuff that you collate and that assumption, what that means, what expertise lives within house.
And I think we'd be very conscious to link it out, certainly. I think that would be a goal because it is not our data. It's not sort of owned within CHIA. It's not to say that's a perfect answer, but I think that would definitely be the goal, would be to link out to those sources that we actually received the data from.
Yeah, that's just the only thing I worry about, is it turning into a public health space.
We appreciate it.
No, this is such an interesting conversation because I admit, I had envisioned this more in line with the other types of CHIA facility profiles with very much kind of a policymaker audience in mind. It strikes me that there's a lot of DPH data out there that would speak to quality or safety concerns about all kinds of licensed facilities, right? That's not kind of aggregated or presented on this kind of snapshot basis, which I agree with the comments that there's a potential for some consumer confusion, less on the CMS star rating, but more when we really kind of drill down into the DPH survey data. So I think your suggestion about perhaps like mocking up a little bit of like what this actually might look like for a couple of facilities might be a really productive next step for the council to kind of get a sense maybe of the kind of situation you described, Lauren, where there could be a real disparity between different quality metrics. Because this would be, I think, a sort of a new role for CHIA and CHIA data as consumers may be, relying on this and the way it's presented to potentially, shape their decisions about where to get care.
Yeah, we can certainly do a
Let's take a
mock-up
look.
and I know that perhaps we can take language that exists. I mean, EHS has a long-term care facility mapping tool, and I feel like I'm having sort of some deja vu about this, how to explain, or reconcile some of these conversations about, or some of the disparities in quality scores. There may be existing language that explains out how each of those scores are formulated that we can cite and maybe point to another entity so that we avoid the inviting a whole bunch of calls.
And I think it lends to resources more than maybe we have in the past to that
Right.
point, that a sort of stronger resource section to this than the typical policy use,
Yeah.
which is helpful to think about.
And there's some sort of like usability testing, right, in terms of just thinking, just like the mock-up would be like and you show it to people and say, does this make sense? So,
Yeah.
Just a little bit.
We have provided information on a number of hospitals. Have we ever gotten calls from consumers? In hospitals, and we have data out there that people can look at.
We've certainly received questions, but most of what we put out, we tend to take those questions and build it into the next version so that those questions don't come up again. But most of the data that we put out, especially in the hospitals, is CHIA collected data, generally speaking. We're not typically
This is-
using outside
this is click
sources
and go
quite as
through.
much. It tends to be our financial statement or our cost report data that's going out there.
And it's a different process for a long-term facility, right? You go to a hospital, it's often urgent.
Yeah.
Whereas, for a long-term nursing facility,
Yeah,
it's
it's
a
more
long.
shoppable. I hate to use that word, but I think it is, I think that's a good point.
So much more interesting topic, I think, than you thought it was going to be. Thank you very much.
No, thank you.
Are you still doing primary care?
All right, I think we'll move into the key priority areas. Erin, Bonnie, and Haley, HIR and SNR.
Thank you for putting your name tags. I always appreciate it.
Yes, so 2-for-1 special today. We're back with some very quick updates on a couple of the key priority areas that we've been giving you all updates on pretty regularly for the past couple meetings. So first up, in terms of primary care and behavioral health, 3 things to just highlight. The first is the primary care behavioral health spending report. So this was published back in August, and it looks at system-wide spending on primary care and behavioral health, as well as spending trends at the payer and the provider level. So the behavioral health data was included in CHIA's annual report back in March, but this report focuses on more detailed analyses and trends. So new this year, we included analyses that looked at spending by age group, payer and provider specific data, and additionally, we're able to break out spending for mental health versus sub-services specifically. So we have a couple key findings here, and in terms of key findings and takeaways, so there's some significant variation in spending for both primary care and behavioral health services across payers. Some of it is expected due to differences in the populations, but as a whole, the key findings show that there is still underspending or not as much investment in these areas. But a quick update on that report that went out back in August. And then in terms of other reports that have been published, so the primary care dashboard was published back in May. So this was the second iteration of the dashboard. And we included an interactive tableau with additional data cuts and detail was something that was new for this cycle, in addition to data updates and some tweaks. Where we're going next in terms of primary care specifically is we are currently in the phase of gathering and evaluating potential new measures to include in the next iteration in cycle 3. A few areas that we are currently investigating or looking at, among others, are from a capacity or provider standpoint. So are they accepting new patients? What are the wait times, either as part of that capacity and that access to services? We're also looking at the broader spectrum of care locations. So are there measures specifically around community health centers or other places that are large players in the delivery of primary care services that we can incorporate into the dashboard? And then additional stratification, so geography, income, that can add additional detail or inform across all of the domains, and that would be in the interactive Tableau. In terms of publication timeframe, we're targeting spring, summer of 2025 for this. So we're just kicking off the next cycle. And then the behavioral health dashboard, so it has not yet been published, but is scheduled to go out this month. So it's the inaugural behavioral health dashboard. We're very excited about it. It includes a static dashboard similar to primary care, so it's going to be PDF. There are 5 domains along access, finance, utilization, quality, and equity. And similarly, there also will be an interactive Tableau that has additional measures and additional stratifications of the data and of the measures that we're including.
So any other questions on the primary care or behavioral health? Look forward to getting continuing updates.
So quick update on the healthcare workforce survey. We this summer have been spending our time on the 2024 Human Service Sector Workforce Survey, which covers a range of provider organizations that serve individuals with intellectual or developmental disabilities, mental health conditions, substance use disorders, those experiencing homelessness, among others. And this survey is currently in the field right now and accepting responses through the end of September 30th. Phone and email follow-up is going to be ongoing through the end of the month in order to encourage survey participation. And she is also monitoring some of the response rates and the quality and completeness of the surveys that have been submitted so far. As of yesterday, about 11% of private human service providers have completed the full survey, and about 36 of the public sector human service providers have completed that survey. As I said, outreach is sort of ongoing to encourage completion, which includes converting some of the partial responses to complete responses. We are expecting sort of more responses right around the survey close on the 30th. Once the survey does close, our analytic team is going to begin to clean some of that data and analyze it and prepare for publication to be included in our dashboard that exists on our website now with the 2023 results. In parallel, we've also been working on preparation for the 2025 full MHCW, which is the Massachusetts Healthcare Workforce Survey. And that will be fielded across all 11 sectors. So the same sectors that were fielded in 2023, with addition to the human service sector. And right now the team is working on developing an outreach strategy, quantifying the survey based on some feedback that we've received during the 2023 cycle, and just taking into other outreach considerations that need to be made. Specifically in terms of the survey instrument itself, I think we're looking to shorten the survey in order to encourage higher response rates. And right now we're seeking feedback on data priorities from state partners and provider organizations just to ensure that all of the key domains are covered.
How is it going? I mean, the due date is coming up.
For the survey closed for human services?
Yeah.
Or,
I
yeah.
mean, are you getting responses back that you had hoped?
Yeah, I think we certainly have done a lot of work with the trade organizations and provider associations to do a lot of outreach, and I think that that's been really fruitful, and we're really looking forward to getting our hands on the data and beginning to really dive in so we can get a sense of quality there. Great. As far as health equity goes, just a quick reminder, this is CHIA's 5-point health equity strategy. As part of that, we have been specifically working on the bolded item number 2 there to expand existing data streams with new sociodemographic information to enhance our current reporting.
In 2025, CHIA is going to request that health insurers submit available sociodemographic data, including sexual orientation, gender identity, race, language, disability information, sex assigned at birth, and member address to our all payer claims database, or the APCD. This kind of more upstream data, as opposed to some of the sociodemographic data that hospitals collect, is going to give us the opportunity to have a more comprehensive view and give us the ability to identify and track disparities in coverage, access, utilization, cost, quality, affordability, all by race, ethnicity, region, and other characteristics that will significantly enhance the type of stratification that we can do in our reporting. The demographic elements that we're going to be collecting are aligned with QMAT data standards and have sort of been endorsed and agreed upon by public and private payers through the Quality Alignment Task Force to ensure basically that we have the same type of data taxonomies and interoperability within and across all of our sort of CHIA assets, which includes EHRD, the new data stream that's collecting some of this information as well. And this is just, using these data standards generally sort of contributes to consistency in the type of data that we have across all state agencies. Most recently in the last month, CHIA has met with some of our state partners, including Mass Health, the Connector, and GIC, to better understand their data collection efforts when it comes to sociodemographic data and to gather feedback on the overall plan. CHIA is going to continue to engage with individual payers later this fall to better understand different data collection strategies and barriers that individual payers may be facing as they're getting this type of demographic information. And we're also working on developing some technical documentation that's going to be necessary for data intake as we prepare for that starting next summer. That's it for health equity.
I noticed that it was on your list of discretionary things that the health equity stuff was, and I think it's really commendable as organizations to be doing that work, even though it's not mandated part of the mandatory work, because it's really important.
Thank you. That was an efficient report. Questions before we dive into your report, Lauren?
All right, seeing none. Just a couple of quick updates I want to tick through. So in terms of the budget, the FY25 GAA was signed into law back in July, and it includes a $33.6 million appropriation for CHIA. So we're pleased with this outcome as it fully funds the agency's work and operations for this coming fiscal year. In terms of, and please feel free to jump in if you have any questions on these as I move through fairly quickly. In terms of a legislative update, so the formal 2-year legislative session, when major bills are debated and voted upon, that ended on July 31st with several sort of major healthcare bills that remain in conference committees. I will note that since then, there have been several bills that have been sent to the governor and signed, including legislation on maternal health and long-term care. Both bills have minor sort of roles or implications for CHIA, largely directing the agency to support with data, reporting, analysis, and for a number of task force and committees that were created through these bills. And then although the formal legislative session has ended, the full 2-year session will fully end at the end of the calendar year. So we'll continue to monitor and sort of be continued discussions with our legislative partners to see if there's any potential developments on the hospital oversight, pharmacy bills, and a number of other bills that we were tracking and monitoring throughout the session, which had, I would say, larger directives and roles for CHIA to play, at least relative to maternal health and long-term care. So we are still sort of in a watching and waiting mode, and I think by our next council meeting in December, have a better sense of if there is any new major legislation that will have an impact on CHIA.
It was an unfair question, I'm sure, but Do we have any sense that there might be any movement?
That's a
I know you
loaded
can't
question.
You don't know.
There have been statements about commitments to getting something done.
So we should all just watch and wait.
Yes.
Got it.
Any other questions on budget or legislation? All right. All right, our favorite EAPCD project update.
This matters, folks.
Yes. So our effort, just to recap, in our effort to part ways with IBM and bring the EAPCD in-house is largely on track. We have hit a number of key milestones to date. So we successfully stood up the replica database, which includes claims through Q3 of 2023 in CHIA's cloud environment. And we've provisioned access to internal and HPC data users. So that was sort of our first big milestone. The next big push for the project is implementing the system that will enable us to update the database on a quarterly basis. So we are, we will start to, as part of that, we will start to layer in different key data categories, starting with reference data with the intent to have a fully refreshed data set. So bringing claims up, more current than what's currently in there now, which is Q3 2023. So have a fully refreshed data set by the end of this fiscal year, which will include the eligibility data, the medical RX claims, among others. So I think standing up the replica was the first big step. We successfully did that. And now we're sort of beginning this next big phase, which allows us to do the thing that the APCD was intended to do, which was allow for those more timely refreshed data. So we don't have to wait a full year, for example, just to wait for a whole nother set of claims data. I think largely on track with there have been some minor wrinkles around recruiting and some of the more technical contractors, but I would say these are wrinkles that are foreseeable in any large project like this. So we don't see any or foresee any material impacts to the project timeline at this point in time. Any questions? Still confident in terms of hitting the timeline targets, the financial targets. We've, from early experience of querying the system, we've been really satisfied with the performance. It's been much faster than the query performance that we saw from IBM. So that is a plus, but we're remaining, cautiously optimistic. But nothing to date has given us reason to believe that there will be a material change to the project plan and timeline.
That's great. Because it's a big lift.
Is staffing at CHIA generally okay, in a broader context of workforce labor challenges in the market? I mean, it's a very specific skill set, but I'm curious.
I would say that it has been primarily stable. I think that there are certain positions that are inherently more challenging to hire or recruit for. And then, there are other positions that we've posted and seen, hundreds of applicants for. So I think it's for a state agency in a sort of niche area, I think that we've by and large are doing okay. If I hear from staff afterwards that is wholly inaccurate, I'll make sure to send a follow-up. But
I'm watching faces, they seem fine.
I'm looking at you, Tanya. Anything you would add, not to put you on the spot?
I think, as you would expect, hiring some of these really niche technical positions has been challenging, but that I think is challenging across all the labor market. So that's where we continue to have challenges. I think CHIA's reputation has continued to make it easier and easier to hire our analytics staff over my time here. So that's really well. It's more easy to do.
Great, thank you. It's good to me.
Thank you. Great question. Thank you, Judy.
Okay, any other questions on EAPCD? Hearing none. This slide is just kind of provides a recap of large publications that we've recently released. So the MHIS, the provider price variation, which looks at relative price, the primary care behavioral health spending report that Erin mentioned, our annual quality metrics. What else am I missing here? I think for the most part, that's what we've put out since June. And then forthcoming in the next couple of weeks, we'll see the hospital fiscal year 23 annual hospital and health system financial performance report, as well as the first ever behavioral health dashboard that Erin mentioned earlier. So that is that's what has recently gone out the door and what's coming down the pipeline in the next couple of weeks. Any questions on publications or the process or content?
Or questions for Lauren in general? If not, thank you. I think we had a really good conversation about the upcoming plan. Great conversation on nursing, which is important, and we will get a mock-up of that. It's terrific. There are lots of updates on priority areas, seem to be moving along, and we will all watch the legislature, see what happens, and we are fingers crossed for the APCD. So do I hear a motion to adjourn?
So moved. Second.
All in favor?
Aye.
Well done, Karen.
Minutes.
Turned out, I think it's making.
Yeah.